Hello, everyone. Thank you for joining our live stream session today with Fireside and Pediatric Dental Anesthesia Associates. I am Allison Farrell, Fireside's Director of Marketing. So, as people are coming in, I'm going to kick it over to our CEO, Bart Yancey, to give a quick message about Fireside, and then we will get started. So, Bart, you are good to go.
Yeah, great. Well, thank you, Allison, and thank you everyone that has joined today. We're excited about this event with Dr. Vila and look forward to hearing his presentation. Very quickly about Fireside, we are a membership exclusive for private practice pediatric dentists. And our members, our private practice pediatric dentist whose overhead is going up, whose profit margins are shrinking, and they just don't have a lot of time to do much about it. There is a higher price to staying independent today. And I think a lot of you on this call may have even seen the impacts of this in your own practice, but the large majority of private practices, profit margins are shrinking. And so Dr. Jeff Flannery, who is another co-founder of Fireside, Jeff, as well as our advisory board, they have really been working hard over the last several years as we've built the organization around Fireside. And it's directed at private practice pediatric dentists who have no leverage or buying power in the market. And when we contrast that with the DSOs in the market, they certainly have leverage and certainly have buying power. And unfortunately, a lot of the private practice are subsidizing those savings for the DSOs. And so that was a big problem. And so that's why we ultimately created Fireside, and our membership is growing rapidly. We're really excited about that. Ultimately, Fireside is allowing our members to stay private and to also experience the advantage of being a part of a group and having leverage and letting our organization go negotiate with manufacturers and suppliers and vendors on your behalf to produce significant savings. And so I'm going to introduce Dr. Jeff Flannery, who is going to talk to you for a minute and introduce Dr. Vila.
All right, guys. Yes, Dr. Jeff Flannery right here, and I do have the privilege to introduce Dr. Hector Vila. He is the co-founder and chief medical officer of Pediatric Dental Anesthesia Associates. We just are extremely thankful for him and his group, Justin, and everything they've done for many, many kids, just all across the country, and pediatric dentists. They really have, just my personal experience, they really have just increased access to care. Our OR list here in Alabama is very, very long. And they've given me the ability to have 2 more sedation days a month. Each day I see probably anywhere from 12 to 14 patients. And, so we're close to almost 30 more patients a month that we're able to see in this kind of way. And just the way that they have created a different way of doing things, made it more efficient, made it very safe, which is actually what he's going to be talking about today. But we are just extremely thankful for this, for their group. And I really look forward to hearing what Dr. Hector Vila has to say today. Dr. Hector Vila, here he is.
Thank you. Thank you, Dr. Flannery. And we appreciate you. We appreciate the chance to be able to work together and collaborate in this kind of way. And we appreciate Fireside for making this platform available to be able to collaborate. We certainly come to the offices and provide anesthesia for the kids, but to be able to work together to improve the care that we both deliver is a unique opportunity, and we certainly appreciate that. Well, Allison, how are we doing with the slides? Are you able to do it, or you want me to share my screen again?
Yes, if you could go ahead and share your screen one more time. Thank you so much. That looks perfect.
Is that good? Okay.
That is good.
Great. Well, the title of this presentation today, and it's going to take somewhere between 25 and 40 minutes to get through, is what can and has gone wrong in pediatric dental sedation. I'm located in Tampa, Florida. Allison, I just want to confirm that y'all can see my slides.
Yes, we can see them.
Okay. Let me just,
We're still on the
all
title
right.
slide. There we
Okay,
go.
good. So here's the disclosure. I am the founding physician for Pediatric Dental Anesthesia Associates. It's a nationwide practice of 41 specialty pediatric MD anesthesiologists, and we exclusively provide services for pediatric dentists. Just a little background on me. I originally had a chemical engineering degree from LSU, went back and got my medical degree from LSU 1989, did an anesthesia residency here in Tampa, finished in 93. I've been in academic and private practice for about 30 years, PDAA for almost half of that. I've also been appointed to the Florida Board of Medicine, first in 2016, continue to serve there. I've been in leadership positions in the American Society of Anesthesiologists, and I was chair of subspecialties and clinical standards. And that there I covered pediatric subspecialties as well as ambulatory surgery subspecialties. So this is kind of falling right into my specialty area. The Quad ASF is an accrediting body that accredits surgery centers, and I was vice president of standards. And again, that's consistent with my academic experience in safety for outpatient surgery. Back in 2003, I was the lead author on this study, which compared outcomes of procedures performed in physician offices. This was like mostly plastic surgeons, urologists, and compared those to ambulatory surgery centers. In this article, we did find that office surgery was not as safe as surgery center surgery, but we looked at the differences and what led it to be less safe. And that's how I kind of began this journey into office-based anesthesia and dental offices. And it was this background that allowed me to be able to dissect the things that make things safe and unsafe. And now what I wanted to do is make sure when we began to do office anesthesia, that we do everything that makes it not only as safe, but I think certainly as safe, if not safer. So the learning objectives for today are going to be, what we'll do is first review some media reports of deaths in dental offices. Then I'll take you to the actual literature and we'll look at the risk of medications, airway events. We'll look at the effects of patient selection and recovery. And we'll look at this popular kind of controversy of intubation versus natural airway. And there is some literature on those outcomes. We'll also look at the importance of training in the anesthesia provider and understand the pediatric dentist's role in the delivery of safe in-office anesthesia. Well, what can go wrong? Let's dive right in to the media reports. This one was 2007, about the time I began PDAA. This was a Chicago case in which a young girl, a 5-year-old, died of oversedation. It was $1 million lawsuit, and the family was quite upset about this. And in the investigation, what they found is that this patient had received 3 times the amount of Valium that the 35-pound patient should have received, and that they oversedated and did not properly monitor her, and so she suffered this terrible outcome. Following that, there was, and about the same time, there was another patient that died in an unfortunate death, and that their family worked to gather other events like that. Raven Maria Blanco died in 2007, and her dentist had given her chlorohydrate, Vistaril, and nitrous. And the autopsy revealed that she had 3 times the average needed, and that was over an hour later. The dentist had also failed to obtain an updated medical history, and this family then began to support this website, which researched and accumulated these deaths starting back, and these are chronologic from back in 2004, and looked at all of the deaths that had occurred that they could collect information on, as well as the cause of death. And so I used this website, I pulled the information, and then I kind of began to group the deaths into, for instance, this grouping, which looked at the causes. And if you look at the ones in yellow are respiratory arrest. And so I began to see that respiratory arrest and overdoses of medications leading to respiratory arrest were the most common causes. Other causes included postoperative causes, as well as there was noted relationships to morphine and other medications. But airway anesthesia-related deaths were far and away the greatest cause. So here's another one. This was a child in Cedar Key. This was 2010, just 3 years later. And this was another 5-year-old that was also sedated with chlorohydrate. Looking now all the way up into 2015, this is a report from California, which was a child that received Versed, fentanyl, and propofol. And in this case, which received a lot of attention, it was noted that the label for propofol specifically mentions that the person administering the anesthesia should not be involved in the surgical procedure. This led to what's known as Caleb's Law, and this was proposed in California and pushed and said for a very young patient that you should have a separate anesthesia provider. It was, this is what I said, it was dedicated anesthesia provider. It was successfully fought by the California Dental Association. This is according to NBC News in 2016, and so was never approved. Here is a more recent case. I'm sorry. Excuse me just a second here. So this case is from Kissimmee, and it was another unfortunate outcome. And in this case, the anesthesia record showed that the patient was not being properly monitored, and the records were not consistent. These are reports from Texas, another kind of an expose that looked at, and in this particular expose, they said that there were at least 85 instances of Texas patients who had died in association with dental procedures in just this short time period. This was the deadly dentistry expose from the Dallas News. Well, this is the one that you probably have seen the most recently. This was just a couple of months ago from San Diego, a 9-year-old patient. And although we don't know a lot about that, what we do know is that the patient was actually successfully sedated and discharged. And then she was discharged. According to the parents, she fell asleep on the way home and never woke up from that. And by the time she got to the emergency room, she had passed away. I do want to talk just briefly, because in this case, it was a dental anesthesiologist and it was general anesthesia. So I do want to just kind of touch on that and just touch on the training, the background and training, and the differences between pediatric anesthesiologists, medical anesthesiologists, and dental anesthesiologists. And if you look at the yellow bars, they are the number of pediatric cases done during training. or the minimal amount to complete the training. And you can see that the program length in months, the pediatric anesthesia is 60 months. Just the regular medical anesthesia is only about 48 months. So you're at least doing another year or two of training following the anesthesia residency. But the number of cases that you do are greatly more specific pediatric cases. So that was kind of the overview of the media of what's gone wrong. And now what I want to try to do is tie that back in to what the literature suggests in terms of what's gone wrong. The media reports kind of give you some ideas, and the inference that I want to bring to you so far is that there's certainly a lot of airway problems. There's a lot of relationship to medications, and in some cases, the patients die during the procedure. In some cases, they die after the procedure. And all of those elements are important to safety. This article is from Pediatrics. This was back in 2006. And it looked at adverse events during pediatric sedation anesthesia for procedures not done in operating rooms, but done, for instance, in radiology suites or procedure areas outside of the operating room. And many of these patients were sedated with either Versed or chlorohydrate, ketamine. About half of them were propofol sedations. And the people that were doing the sedation were anesthesiologists in many of the cases, only about 20%, but there were also ER doctors, intensivists, and pediatricians that were also participating in this study. So it wasn't just anesthesiologists. What did they find were the adverse events? These are adverse events. Well, death and cardiac arrest, there were no deaths at all in this controlled study. There was a cardiac arrest, an aspiration, and others, but what were the main ones down here in the bottom? Prolonged sedation, apnea, secretions, vomiting during the procedure, and you can see desaturation was the greatest one down at the bottom, the greatest number of cases. And those were significant desaturations. They were down in the less than 90% range. And in terms of treatments, it was airway interventions as well as bag mask ventilation. Those were the largest numbers of treatments. So this is suggesting that even in this controlled study, they saw the same kind of problems that we've seen in the media reports, which is it's a lot of airway events. Another study, the same research consortium was a part of this study. This is from Anesthesia and Analgesia in 2009. And it looked at also procedures outside the operating room, and this time mostly propofol, but it found the same thing in terms of serious complications were airway obstruction. Risk factors for adverse events. This is a very important slide. And so it shows that care which is not too surprising, care is safer with an anesthesiologist that specializes. And I think that's consistent like with what you do as pediatric specialist. You understand the elevated level of training and expertise you have in the area. The ASA3 is the physical status of the patients. And so the sicker patients had additional risk. Very young patients, less than 6 months of age, also carried a greater risk. The patients that were not fasting, that had not been NPO, had a greater risk also. But one of the greatest risk was down here at the bottom, and that is the patients that were either given opioids as part of the anesthetic, and the patients that suffered respiratory complications with opioids was again the highest category. So this is beginning to point not just to the anesthetic medications, but indeed implicate opioids as one of the riskiest medications to use. Now what I want to do is, because we talked a lot about airway and breathing problems, I want to just bring up cardiac arrest. And this is to address the issue, how likely is it in your practice that you're going to see a patient come in and have a cardiac arrest as a primary event, not as a secondary event, not because the patient stopped breathing, became hypoxemic, and then suffered a cardiac arrest, but how often are just primary cardiac arrest a problem in pediatric anesthesia. And so this looked at two different time frames. One was before 1998, and that's the first column. And so this right column is 1994 to 1997. And then after 1997, which is 1998, so there was a greater number of arrests in the earlier time frame. And that's because during that earlier time frame, there was an anesthetic gas that was used called halothane. And it will later show that most of these arrests were related to halothane, which is cardiotoxic. It's a very potent cardiac depressant. And so you could, in overdoses of halothane, see a primary cardiac arrest. After that, in this second group, you saw less arrests. But again, this slide is going to summarize that. There were 193 arrests related to anesthesia, so about 49%. Medication-related arrests were about 18%. But the most common cause was not even medications. The most common cause was these pediatric patients that were coming from a trauma that had bled out. So they were either hypovolemic or they had hyperkalemia. So medication related, so if we're sedating a child in the office with propofol, it's very unlikely, in fact, almost no reports of primary cardiac events. Now, if there's an inhalational anesthetic such as halothane, which most folks aren't using anymore, there you could worry about a primary cardiac event, but not with straight propofol. This is from your journal, Pediatric Dentistry 2012, and it looked at adverse events during pediatric anesthesia, and it was a review of closed malpractice insurance claims. There were 17 claims, 13 involving sedation. I'm sorry. Let me back that up. 53% were death or brain damage. 6, there were general dentists as the anesthesia provider. Of the 13 claims involving sedation, only 1 involved the use of proper physiologic monitoring. So this was certainly alarming that there were all these deaths, but there's, at least from a standpoint of finding something that could be done better, certainly the ones that involved the death without physiologic monitoring were riskier. And I think you've seen the evolution in all of the state boards now, not only requiring monitoring such as CO2, but you've seen them doing more inspections before they're giving permits. This article is Trends on Death Associated with Pediatric Sedation. It's from Pediatric Anesthesia, 2013 article. And it actually looked at, remember I told you in my earlier slides about Raymond Maria Blanco Foundation website. So this article looked at some of the same stuff that I looked at. So this is another summary of that. It looked at patients from 1980 to 2011. And what did they find? They found that indeed most of the deaths were 2 to 5-year-olds, so the very young ones. This was 21 out of the 44 deaths. Most of them had occurred in the office setting, and most of them involved a general or pediatric dentist as the anesthesia provider. They did find, just to give you some other causes, 3 of the deaths were pre-existing medical conditions. One was a Treacher-Collins syndrome. Another one was a congenital pulmonary stenosis. And then there's a 13-year-old with 13-month-old with an undiagnosed cardiac defect. So preoperative selection is important. This is highlighting these risk factors, I think, should tell us that. So all patients that are going to receive a sedation anesthetic in a dental office should have a preoperative evaluation with a risk selection. Several reports also indicated that deaths were related to inadequate resuscitation, and I think that's where we're going with practicing for resuscitation. I know our group does that every year. It's part of the mandatories for the physicians as well as our nurses. So you have to practice. You can't just, when something happens, think that you're going to be able to sort of read the manual on how to rescue a child from an airway problem. The cardiac arrests were all related to initial respiratory arrest. This is a table of the deaths, the number of deaths, and you can see most of them occurred with a general or pediatric dentist as the anesthesia provider. There were certainly some oral surgery deaths. The anesthesia deaths, one of them, the anesthesiologist, one was in an office, 4 were in the hospital or surgery center, and 2 of them were not reported. The predominance of respiratory arrest, the number of sedations, age distribution suggested that the depth of sedation was a common pathway. And what they're saying here is that many of these patients were scheduled as sedation anesthetics or moderate or conscious sedation anesthetics. And in fact, they were so deep and there was a loss of the airway, which suggests that even though they were advertised as conscious sedation, they really were either deep sedation or general anesthesia. And that's because, as by definition, anything that's minimal or moderate should be able to maintain spontaneous ventilation and should not end up in a respiratory arrest. This is an article that looked at morbidity and mortality. It's a more recent article out of Ontario, Canada. And their objective was to look at mortality and serious morbidity in Ontario from 1996 to 2015. So they went out and did a survey and asked and collected information. And what they found in terms of the deaths, that there were 2 deaths with physician anesthesiologist, 1 death with a dental anesthesiologist, and 1 death with an oral maxillofacial surgeon. And these were the number of cases that were performed by each one of those. This is some data from back when we first started the practice, and we looked at complications. This is kind of to give you an idea of what other data besides just deaths are collected. So we looked at laryngospasm. I know that many of you know what laryngospasm is. It's very scary when it occurs. This was an office-based anesthesia study that was published in the Journal of Oral Maxillofacial Surgery, 2007. This was a hospital dental article that was published. And then this is the sedation consortium data that I presented to you earlier, that article of 50,000 cases. So laryngospasm can range anywhere between a high of 14 per 1,000. The sedation consortium was about 2 per 1,000. And our data from PDAA, this was back when were only doing about 7,000 cases a year, was about 0.6. Since I presented about how many cases a year we were doing, I wanted to show you back in 2019, we were doing right around 10,000 cases a year. In 2023, we did over 30,000 cases a year. And this year we'll do well into 40 and almost 50,000 cases. And we do collect some data. This is the data that we collect on our practice. So this was from back in 2023. We did 34,000 cases, and we collect data, for instance, on laryngospasm, and the incidence of laryngospasm was about 3.3%, which it was in that previous study that I showed you. In terms of pain, nausea, or fever, or cancellations, we collect all that data also. And over the entire period since PDAA has been in practice back in 2007, we've not had a death or a serious injury. Now, we wanted to get some other real data and more recent. If you notice, most of what I presented to you is like 2017 and before. So PDAA went to the Florida Dental Board, and in Florida we have a very open reporting of any of the state data. And so we were able to do a Freedom of Information Act request. And so we asked the Florida Dental Board for all of their adverse occurrence reports. There's mandatory reporting in Florida. If you have an adverse incident, you have to report it. So we looked back from 2017 to 2021. So 5 consecutive years. And they gave us all of their reports. There were 68 reports of adverse incidents reported during that 5 years. There were 23 deaths or cases resulting in CPR of those 68 reports. There were 17 cases of near misses where there was rescue, sent to the hospital, for instance, with no post-op complications. And then there were 28 cases of patients with no post-op complications, but were not serious enough that were like a major rescue. So as we broke those down, we wanted to know how many were in pediatric dentistry. During this time, again, 2017 to 2021, there were only 3 reports that came from pediatric dentists. There were no CPR deaths, no near misses, and so all 3 were rescued. We'll talk a little bit more about those 3 in just a moment. There were 27 adverse incidents in oral surgeons' offices with 9 deaths, and another 10 near misses. So these are patients transferred to emergency room and sent home. General dentist had 21 adverse incidents, 7 deaths. The periodontist had 12 and 5 deaths. Endodontics, 1 death, and prosthodontics, 1 death. So 23 total deaths in the dental offices. And the good news in pediatric dentistry is we didn't have any of them. The 3 cases that were sent to the hospital and therefore required an adverse incident report, a child with some hemophilia who had extractions, question about bleeding. So this child was transferred and received factor 8, which helps to stop the bleeding. The child was discharged without complications. This 3-year-old was cared for by one of our pediatric anesthesiologists, and this child developed SVT during IV sedation. It was recognized because of the EKG monitoring we do. Patient was evaluated, transferred to the Children's Hospital, evaluated, and discharged by cardiology without complications. There was a 10-year-old child that also suffered a seizure, autistic child, was transferred just for, in fact, I think this patient actually, EMS was called, and so it was reported, but I don't think this patient was ever even transported. And yeah, that's what it says on the slide. So of the 23 cases of death, we did want to kind of give you a little bit of background. Most of them were adults in advanced stage, and nearly all of them involved the use of IV narcotics and opioids, and many of those with the combination of opioids and benzodiazepines. Several of them had a lot of significant risk factors, coronary artery disease, histories of congestive heart failure, diabetes, and so forth. Several of them also had histories of asthma. But the one recurrent theme is that the IV sedation was administered by the same dentist that was doing the anesthesia. We'll touch briefly on the issue of the controversy of intubated versus non-intubated airways, and this article is specifically in children. And it came from the Journal of Pediatric Dentistry. This was in January, February of 2019. What they looked at, and this slide is to tell where the complications occurred. And so if you look at the patients in the last line down here, these are the patients that were intubated. These patients had a laryngeal mask airway. There were very few of those, but these patients, which is the next largest group, which is about 40% of the patients, had just either a naso or oropharyngeal airway. So it was kind of the natural airway patients. And this is the incidence of complications. And so you can see it was 0.6% here. And the intubated cases, the incidence of complication was 0.6%. The authors of this were the dental anesthesiologists, many of which intubate the patients. And so I think this article, I believe, sort of settles the debate on whether it's safer to intubate pediatric dental patients than it is to do them with an open airway. I'm sorry, wrong direction. So, coming up with some conclusions, when we look at preventable pediatric sedation deaths, I think that the main thing that we should worry about and focus on is respiratory complications. It's the respiratory arrest, the respiratory depression, or the loss of the airway that leads to the cardiac event. We don't have to worry about primary cardiac events so long as you're doing an adequate preoperative screening. I think it's always important to do a physical exam. Obviously, we do it in our practice. If you're going to be sedating patients in your practice and doing oral sedation, not only taking a history, but doing a physical exam. If you hear a big murmur, I would back off. But primarily, you're going to be worried about respiratory events, and the primary culprit of that is opioids. So if opioids are a part of your anesthetic medication regimen, you certainly have to have a heightened awareness and be very careful with them. And if it's opioids involving multiple drugs, even more so of a problem. Talked about the medical conditions. Obviously, monitoring is very important. Inadequate rescue, you can deal with that by doing yearly emergency drill practices, and we highly recommend those. Our group has some recipes for those, and we have some checklists that we use, and we'd be happy to share those with you. The training of the anesthesia provider is very important, and whether you're doing both the anesthesia and the dentistry, and making sure that you're allocating someone to be watching the monitors and monitoring the patient, and not involved with the actual procedure itself. And I did want to point out there've been, just to give you some reassurances, because I know we have relationships with most of you, that we've had no deaths with a pediatric anesthesiologist. And I think we've settled the issue whether there's a difference between IV sedation and general anesthesia and intubating the airway. So with that, I know I kind of raced through it. I'm happy to entertain some questions